Thank you very much for this nice introduction and also for this nice invitation to give this presentation. And congratulations that finally Artesunate for injection has been FDA approved in the US, and you can move away from that very toxic quinidine drug. So I'll share my screen. It's over here. I hope you can all see it.
Yes, we can, Arjen.
Okay, so I will not focus too much on IV artesunate for severe malaria. I, of course, will mention the trials, but rather give an historical overview how this drug was developed almost 50 years ago now, how it is used in the artemisinin-based combination therapies, the worrying development of resistance to the artemisinins that we are experiencing here in Southeast Asia, where I'm based, and then a bit about the treatment of severe malaria with IV artesunate, and this adverse event effect of late hemolysis that you can expect in your patients too, when you treat patients with IV artesunate. And then we have a lot of time for questions at the end. So we talk about an old drug, but also a very old disease. So it's been with humans for thousands of years, and it's the disease that has really shaped the human genome more than any other disease, because there are several polymorphisms that protect against malaria, and most well known is a sickle cell trait, which is very common in Africa. It has reached an Hardy-Weinberg equilibrium, very common, the sickle cell allele, and you can, by the way, you can from that calculate that in the pre-treatment area, around 16% of all children in Africa in areas of high transmission would have died from malaria. So it's really a big disease. And still in high transmission areas, in resource limited settings in Africa, around 12% of all children will develop severe malaria at some point in their life, till around the age of 5, because then they have acquired sufficient pre-immunity, not full immunity, so that they won't develop severe disease anymore. But of course, in low transmission settings or in travelers, you will see severe malaria in every age group. So a very old disease, and the artemisinins are also a very old drug. They are made from this plant, Artemisia annua. You see that there on the left side. Only certain plants, and it also depends on the soil and many other things, have a good yield of artemisinin, and the first descriptions come from the 3rd century from China, where it was used for febrile diseases, and then it was forgotten for quite a while. And then it was rediscovered by the Chinese in this, it was called Project 523, because the project started in May 23rd, 1967 in China. It was a secret military project in the context of the Vietnam War. So Ho Chi Minh and Zhou Enlai, they said they really needed better anti-malarial treatment. Chloroquine resistance was already started, and a lot of their soldiers died from malaria. And this huge effort with around 500 scientists in the context of the Cultural Revolution, but they were allowed to work on it, tried to come up with new treatments for malaria, and they screened a lot of natural products. Many people were involved, brilliant chemists, brilliant clinical scientists. I personally know Professor Lee, who's there on the left corner. But Tu Youyou, you might know, received the Nobel Prize in 2015 for the discovery of the artemisinins, from which and artesunate is one of the derivatives from that. So many people were involved. So they not only discovered artemisinin, which is an extract of the plant, but also they made these derivatives from the artemisinins, artemether, which is fat soluble, artesunate, that has just been approved by the FDA, which is water soluble. Both these compounds are rapidly hydrolyzed to dihydroartemisinin, which is the active metabolite, which, by the way, is also made as a drug in itself. And it's a very peculiar chemical structure because it has this endoperoxide bridge that you see in all these pictures, which is very reactive and is activated by ferric heme, which is in the parasite fruit vacuole. That is the idea of the activation mechanism that most people believe. And then it's sort of a cluster bomb. It's alkali, many proteins in the parasite, and kills the parasite. So the first publications on it come from China in the end of the 70s. When the Vietnam War was over, it became less secretive, but by then they had been using the drug already for several years. And it only became known to the Western world after the first publication in the Lancet in 1982. Keith Arnold is on that picture there, an American working for Roche, was heavily involved in that study. And they already then showed that the artemisinins were very rapidly acting, much faster acting than the other known antimalarial drugs at that time. And until today, it's the fastest acting antimalarial drug that we have. You see that here in this graph. So every 48-hour erythrocytic life cycle of the asexual parasites, there's a 10 to the 4th decline in the parasitemia. So an average adult with uncomplicated malaria starts with around 10 to 12 parasites. After a 3-day treatment with an artemisinin combination therapy, I will come back to that later, only a few hundred to 1,000 parasites are left. Other antimalarials are much less potent. So, for instance, quinine or quinidine only kills around 100 times parasites per erythrocytic 48 cycle. So very fast acting. Nevertheless, if you treat uncomplicated malaria with a 3-day course, you cannot rely only on the artemisinin derivative, because although it's very fast acting, you still have some parasites left after 3 days. And all the artemisinin derivatives have a very short plasma half-life of around 1 hour. So after 5-6 hours, the drug is gone. So you need a slower eliminated partner drug to get rid of the tail ends of the parasites. And you see that here in this graph. By the way, the red part of that graph is what happens in artemisinin resistant parasites. I will come back to that later. But here the message is you need a slower eliminated partner drug, which doesn't need to be too potent, but to fully clear the parasitemia. There's another phenomenon, a small part of the parasites after artemisinin treatment go into sort of a dormant state, dormancy, that you can recognize light microscopically, and they also need to be cleared by this partner drug. It's also the reason why when you treat your patients with IV artesunate, until the patient is able to swallow an oral drug, you still have to give him a course of an antimalarial to fully clear the parasitemia. So now quite a bit on artemisinin, on drug resistance, and later on artemisinin resistance. So when the artemisinins were introduced in the 90s in Southeast Asia, the situation was quite dire because all the available drugs had lost their potency. So the falciparum, the Plasmodium falciparum parasite was becoming more and more resistant. We had lost chloroquine, we had lost sulfadoxine-pyrimethamine. Quinine could still be used, but is a 7-day course, a lot of side effects. Mefloquine was introduced at 50 milligram per kilogram dose, later replaced 25 milligram per kilogram, but was also rapidly lost. So, malaria was going up, malaria attributable mortality was going up here in Southeast Asia. So we were really saved by the artemisinins. Great drug, so I already said they have high potency, rapidly acting, but another characteristic is that it already kills the younger erythrocytic stage parasites. So you see that in that cartoon, the parasites develops from a ring to a trophozoite to a chiton state. All other antimalarials only kill the trophozoite and chiton stage parasites, but artesunate already kills ring stage parasites. That's one of the reasons, by the way, why it is so good for the treatment of severe malaria also. In addition to that, it also kills the gametocytes, the stage 1 to early stage 5 gametocytes. So it also reduces transmission of the disease. Not so important when you're in New York, but quite important when you're in an endemic area. So it was not only Southeast Asia, although there the resistance problems were most prominent. Also in Africa, in the 90s, malaria mortality was clearly going up. And a big driver of that was, in addition to DDT resistance, was also chloroquine resistance. That was widely used. It's one of the most used drugs ever. But in the 90s, there was really widespread chloroquine resistance in Africa, but still widely used. And you saw, especially in East and South Africa, where chloroquine resistance was most prominent, malaria attributable mortality was going up, whereas overall childhood mortality was going down because of improvement of the health system. So also there, it was really needed to change the first-line treatments for falciparum malaria. And it took quite a while before the artemisinin combination therapies were introduced there. It's required a lot of pushing, especially by academic groups. But in the end, in 2006, the WHO recommended artemisinin combination therapies for the treatment of falciparum malaria in every endemic country. Nowadays, we have 6 different artemisinin combination therapies. I list them here, except for artesunate sulfadoxine pyrimethamine. All these are now produced as fixed dose combinations. The latest addition is artesunate pyronaridine. I see someone raise a hand. Would you like to interrupt during my talk or keep the questions till the end?
Keep the questions to the end, Arjen. Would that be okay?
Yeah, fine with me.
Okay, great.
So these are the current artemisinin combination therapies that are available. And now it's very widely used. So more than 400 million treatments with ACTs every year, mainly in Africa, where more than 90% of malaria is, although Southeast Asia, India still has quite a bit of malaria. And it has been modeled that the ACTs are an important contributor to the lives saved with the malaria control measures. So in addition to impregnated bed nets and indoor residual spraying with insecticides. So a very important role of the artemisinins. So we were quite worried when we observed on the Cambodian-Thai border that the potency of artesunate was going down. And we could observe that this very rapid killing, as I told you before, 10 to the 4th per 48 hours, reduction was reduced to only 100-time reduction. And you see that on the left-hand graph, where the purple and the green one is what you expect. But then in Western Cambodia, we saw this much slower clearance by artemisinins. A few years later, the genetic marker of artemisinin resistance was discovered. I won't go into too much detail, but it's in the Kelch gene of chromosome 13 of the parasite. Many different SNPs or mutations are possible, and most of them in the propeller, so-called propeller region of this gene, confer this slow clearance phenotype. And that is shown on the right-hand side, and you see all these different SNPs that are possible, that are mutually exclusive. The parasite somehow only allows one mutation in this gene to keep the parasite viable. And most of them are associated with artemisinin resistance, which is great for surveillance and monitoring of the problem. So it was not the first time that antimalarial drug resistance started in Western Cambodia. It was observed before, both with chloroquine resistance and pyrimethamine resistance. Pyrimethamine used in sulfadoxine pyrimethamine. Both great drugs, but now much less useful because of drug resistance. Started in Southeast Asia and then traveled westward to India, crossed the ocean to Africa, and as I showed before, has caused a lot of death in African children. So it also always starts in these low transmission areas, and there are several reasons for that. In Africa, a child gets infected almost every day by an infected Anopheles mosquito. So there are multiple clones during the infection. So if one of the parasites has a resistant genetic makeup, there's a fair chance that in the sexual stage in the mosquito, because of crossing over, it loses this genetic makeup. Another fact is that in high transmission areas, there are a lot of asymptomatic children and adults that do not seek treatment. So the antimalarial drug pressure is much lower in these settings. So less opportunity for development of drug resistance, and immunity is more. So if there's just a little bit resistance, the human host can still clear the parasites and it will not be transmitted to the mosquito again. And then there's somewhat, all these things are not absolute, but Anopheles species from Africa are less susceptible to infection with Asian or South American parasites. So it always starts in low transmission settings, but why always in Western Cambodia? We don't absolutely know. Drug use was very poor, a lot of unregulated drug use. You see that in that picture in the right corner. So over the counter, if you go to a shop with a fever, you get these little bags with several drugs in there. Some not anymore, but still like 15 years ago, artesunate monotherapy, 2 capsules of amoxicillin, a few paracetamol. So a lot of drug pressure came from monotherapy in incomplete courses of the drug. But still, and then this monotherapy had been around in Cambodia for a long time, since the early 90s of the last century. But still, it is a bit puzzling because the other countries also have this poor drug use. So the idea is that something in the parasite strains from Cambodia is different, and there are clues for that. So the artemisinin-resistant parasites not only have this mutation in the CALG gene, but there is also a genetic background that is quite consistent with additional mutations, ferredoxin and apicoplast mutation, that somehow support this CALG mutation to be successful in the parasite population. In the middle part, you see there's also seemed to be something with the DNA repair mechanism, mutations in that part of the gene. And that might fit to earlier observations that parasites from Cambodia, it was easier to induce drug resistance in the laboratory. And then finally, if we look at the transcriptome of the parasite, we see transcriptomic profiles that are clearly associated with artemisinin resistance. And for instance, there's an upregulation of this unfolded protein response, which is a stress response to oxidative stress. And as I told you before, this endoparasite bridge that opens up in the artemisinins, the artemisinins act through an oxidative mechanism. So that could well be the case that these parasites are a bit different in Cambodia. Artemisinin resistance, it's not the full cycle that becomes resistance. It is these ring form parasites that become much less sensitive. As you know, the more mature forms, the trophozoite and schizon stages of the parasitized red blood cells, they disappear from the circulation and sequester in the microcirculation. These young ring forms are the ones that you see in your peripheral blood smear, and those are the ones that become less sensitive. So that's why you see this much slower clearance of the parasites. This has consequences for the efficacy of the artemisinin-based combination therapies. It's a combination therapy, so both of the components contribute. As I said before, you always need this partner drug to mop up those last, say, 1,000, 10,000 parasites. If the parasite is completely resistant to the partner drug, you will still see high treatment failure. But in infections with artemisinin resistance, you need a much more potent partner drug. And that's what we observed. So that now started around 10 years ago in Southeast Asia, especially in the Greater Mekong sub-region. Since we have the molecular markers for artemisinin resistance, but also for mefloquine resistance, one of the partner drugs, you see that stepwise increase in treatment failure, depending on whether you have artemisinin resistance only or mefloquine resistance only, or a combination of the two. Mefloquine resistance is linked to this amplification of PFMDR1. And we have observed the same with dihydroartemisinin piperequine failure, huge problem in mainly Cambodia and Vietnam. We also see this stepwise reduction in efficacy depending on resistance to only the artemisinin component or also the piperequine parts. The right part I will not get into too much, but it shows that because of the slow terminal half-life of piperequine with a quick clearance early on, a small jump in the IC50 gives a much more reduction in the time above the MIC than with other antimalarial drugs. It's not only higher failure of the ACTs, but also artemisinin resistance facilitates the appearance of partner drug resistance. And that is because after the 3-day course, instead of 1,000 parasites, now you have 10 to the 6th or 10 to the 7th parasites left that have to be mopped up by this partner drug. The parasite only sees monotherapy partner drug, and then resistance to the partner drug appears much easier. And we have been able to observe that very clearly on the Thai-Myanmar border, where artesunate mefloquine was introduced in the early 2000s, already late 90s, at a time that there was mefloquine resistance, but the combination was highly efficacious until artemisinin resistance appeared in 2011. And then you saw rapid re-emergence of mefloquine resistance and high treatment failure, which is the red line there of the artesunate mefloquine combination. So we had to switch away from artesunate mefloquine to, at that time, DHA piperequine. And once you have treatment failure and you have recrudescent infection, then resistance will spread as a wildfire. Not only do you have these recrudescent infections that can then propagate further, but also the recrudescent infection always have higher gametocytemia rates and higher gametocytemia, and are, because of that reason, more transmissible. Sometimes they're not as viable, but in general, they're more transmissible. And then you get more resistant malaria, more clinical cases, in the end, more malaria deaths, more drug use, more drug pressure. So then you have this circle going around. And also this increased gametocytemia is also without drug failure already visible. So we see more gametocytemia in artemisinin-resistant infection. And this gametocyte killing effect of artemisinin is also reduced in artemisinin-resistant parasites, which both the males and the females, what you see there on the right-hand side. I won't go into that in too much detail. Okay, so that's what we observed over the last 10 years in the Greater Mekong subregion. In Cambodia, there was a single lineage that was hugely successful with this C580Y Celts mutation. Single lineage spread very rapidly throughout Cambodia, southern Laos, southern Vietnam, northeast Thailand. Picked up piperequine resistance, whereas DHA piperequine was the first line treatment. I have a next slide where you will see that then there was very high treatment failure with DHA piperequine. On the other side, so there's sort of a corridor in Thailand where you see little malaria. So on the other side, you saw a different C580Y mutation being successful, and another Celts mutation, the 446I mutation that spread through Myanmar. And this is showing the very high failure rates with DHA piperequine in Cambodia, southern Vietnam, leading to an increase in malaria during that time. And they had to change their first line therapy. So this is the situation at the moment. As I showed you earlier, we have 6 different ACTs. In Cambodia, 4 of them cannot be used anymore because of drug resistance. Thailand and Laos are a bit less of a problem, but still this artemisinin resistance with on top of that partner drug resistance is more and more a problem in the Greater Mekong sub-region, and there's now a very aggressive effort to try to eliminate all falciparum malaria, because that's the only way to get rid of that dangerous parasite and prevent its spread to outside this region of the world. A lot of funds available for that, and in fact it's quite successful, luckily. And the numbers have gone really down. So the chance that you see a traveler from Thailand or Cambodia with falciparum malaria has become quite low. So what about Africa? What we all fear, that artemisinin resistance will arrive there. So we have this very good molecular marker, mutations in the CALCH gene of the parasite. When surveys are being done, you always find a few 1–2% of parasites that can carry CALCH mutations, but this is just the background mutation rate. It's a very conserved gene, not many mutations. Still, there, just by chance, you can catch a few of those mutant parasites. It only becomes a worry when you see clearly signs of selection of those parasites. And we didn't see that for a long time until recently. So over the last few years, more and more convincing reports from Rwanda, where this CALCH 561H mutation has now clearly established itself. Luckily, the artemether-lumefantrine first-line treatment is still effective there, but it's very worrying. And even more recent, the American CDC group, together with the University of California, San Francisco, has described in Uganda artemisinin-resistant lineages the A675V CALCH mutation. So it's definitely now also starting in Africa, and it has emerged there independently. So the fear we had that it would spread from Southeast Asia has not happened. It's homegrown artemisinin resistance. For Rwanda, maybe to do with that, the transmission had clearly gone down 10 years ago, making the parasite more susceptible to resistance. And this is the recent publications from Rwanda, where now around 13%, it has even increased since 2018, of the parasites are artemisinin resistant. So if you are working in New York, at the moment, you don't have to worry too much if you get your patients, most patients with falciparum malaria will have acquired the infection in sub-Saharan Africa, but it might well change over the coming years. Also in South America, artemisinin resistance had been identified in Guyana, this same size 580Y mutation, but somehow it disappeared there. Maybe it lacked that backbone genetic makeup to make the mutation successful. So, although you have just registered Artesunate, it is getting more and more important to have new non-artemisinin-based antimalarial therapies, because we heavily rely on the artemisinins at the moment. There are no real alternatives. Melurone is good for prophylaxis, but not so good for treatment, especially in endemic settings, because you develop very rapidly resistance to the atopic. So there are some promising new compounds, especially these two are the furthest in their development, the spiroindolones codename KE609 or cipargamin, and the imidazolopiperazines, KF156 or ganaplacide, both very potent drugs, especially spiroindolones also kill these ring-form parasites like artesunate, very rapid parasite clearance, but still have to go in phase 3 trials, and we can still lose them somewhere during their development. For instance, spiroindolones are quite sensitive to resistance development. This is, by the way, the slide from the MMV, the Medicine for Malaria venture, who coordinates anti-malaria drug development. If you see over the years how many new promising drugs have been lost, it's quite impressive. Just over the last year, these 3 compounds that I list there, OZ439, DSM-265, and MMV-048, all seemed quite promising, but the development has stopped for several reasons. So most people think that new antimalarials will be around 5 years away from now. So we have to do it with the antimalarial drugs that we have at the moment. So if you have ACT failure, what other options are there left? You can combine 3 drugs instead of 2 drugs in the artemisinin combination therapy, so-called triple artemisinin combination therapies. And you can think of several combinations. Our unit does quite a bit of research on them, and we try to combine those partner drugs that have different mechanisms of action and ideally have counteracting resistance mechanisms. The 2 most promising ones at the moment is artesunate, piperacin, mefloquine, and especially artemether-lumefantrine plus amodiaquine, but another 2 triple therapies are currently being tested: arterolane, which is a synthetic endoparasite, piperacin, mefloquine, and artesunate pyrineridine, atovaquone. Other possibilities are to give a longer course of an ACT regimen. Has not been tested against resistant malaria. It is safe to give, we know that. Sequential use of 2 different ACTs has not been tested, but in theory, instead of putting them in 1 pill, could also work. What is currently being done in the Greater Mekong subregion is to rotate the different ACTs. For instance, in Cambodia, when DHA piperacin failed, it moved back to artesunate mefloquine. Resistance to mefloquine is slowly reappearing there, so they will have to move to their next ACT. In practice, that shows to be very cumbersome for programmatically to do. In Cambodia, it took 2 to 3 years to make that shift from DHA piperacin to artesunate mefloquine, because of several reasons. So this 2 quick slides, or 3 quick slides on the triple artemisinin therapies. So if you have artemisinin resistance, you have much higher parasitemia left after 3 days of treatment. If you expose those parasites to 1 partner drug, big chance that you develop resistance to the partner drug too. If you combine 2 partner drugs, they can mutually protect each other. And this is what we are testing now in our clinical trials, artemether-lumefantrine plus amodiaquine, here as a co-packed formulation, but it will be made into a fixed dose combination, hopefully in the coming year. The rest of the presentation will be about severe malaria. As a quick introduction, which is also important in the discussion on artesunate, is the pathophysiological hallmark for severe malaria, which is sequestration of the parasitized red cells in the microcirculation. So you see there in the higher panel the ring stage parasite developing to a trophozoite when you see the pigment appearing, and then when the nucleus divides, we call it the schizons. Well, those trophozoite stage and schizon stage very, very effectively sequester in the capillaries and the post-capillary venules of vital organs. So if that mainly happens in the brain, you develop cerebral malaria. If it happens in other organs, you can develop organ failure there. It also causes anaerobic glycolysis in the tissue with high lactates. Lactates very strong prognostic significance for death in patients with severe malaria. Very important to know when you admit a patient with severe malaria. You can see it in autopsy, so electron microscopically or in light microscopically, as you see there, but also in the living patient in the retina. You see this whitening of the retina, which corresponds when you do autopsy with areas where there is heavy sequestration of the capillaries in the retina with parasitized red blood cells. So artesunate, having this big potency, especially to kill those ring stage parasites, preventing them from maturing and sequestering in the microcirculation. We think that that is one of the main reasons why you see this massive decrease in mortality when you give artesunate compared to quinine, which was before then the first-line treatment for severe falciparum malaria. You had to use quinidine, which is related in the States because quinine was not registered. But the mode of action is comparable. And we did these two big trials. We started with a big trial in adults, mainly adult patients in Southeast Asia called SEQUAMET, 1,461 patients, a 35% relative reduction in mortality. That was not sufficient to convince our African colleagues to change to artesunate. So we did an even bigger trial in African children with severe malaria. And there we observed a 23% in relative mortality, big difference, many lives saved. By the way, the less effects, relative effects in Africa is related to the fact that there's around 15 to 20% misdiagnosis of severe malaria because of this background asymptomatic carriage of falciparum malaria also in children. So a huge beneficial effect, which is not at the expense of an increase in neurological sequelae in the 50%, around 50% of patients with severe malaria that present as cerebral malaria. And that you see in this slide where the neurological sequelae, so severe motor impairment, cortical blindness, speech or hearing impairment, was not significantly different between artesunate and quinine. So that trial was published in 2010 and immediately was adopted by the WHO. Artesunate became the first-line treatment, also based on this meta-analysis where SEQUAMET and AQUAMET were taken together. So the overall odds ratio for death was 0.69 compared to quinine, very, very, very significant. Then the uptake in African countries of parenteral artesunate, you can give it IV, but it's also well absorbed when you give it intramuscular. Took quite a few years, but now it's really used everywhere. And it has been estimated that around 500,000 lives, or maybe even more, have been saved just by the implementation and deployment of parenteral artesunate for the treatment of severe malaria. So this shows again that it's probably mainly this effect on the ring stage parasite that gives artesunate this huge advantage over quinine therapy. So therefore, it's really worrying, this artemisinin resistance, where we see a reduction in the sensitivity, especially of the ring stage parasites for artemisinin. Luckily, there is so little malaria left here in Southeast Asia, in the Greater Mekong sub-region, that we see very little severe malaria. There are a few case reports, though, where patients treated with artesunate that carried this CALT mutant showed a very slow or no response to IV artesunate, and had to be rescued by quinine therapy, and one of those patients died. That said, in southern Vietnam, where there's also a lot of artemisinin resistance, a recent observational study did not overall see an increased case fatality of severe malaria in their patients treated with IV artesunate. But it gives a rationale to, when you have a patient with severe malaria coming from the Greater Mekong sub-region, to give a combination of IV artesunate with IV quinine, which we know is safe to do. Except in the US, you will have the problem that you do not have access to quinine. Then the last few slides are about an important side effect of when you treat patients with severe malaria with artesunate, and this is so-called post-artesunate delayed hemolysis, which is quite a puzzling side effect if you don't know the mechanism, and the mechanism is quite interesting. So this is the observation: when you have especially non-immune travelers that come back with severe malaria, treated with IV artesunate, especially when they come in with high ring stage parasitemia. So parasitemia is, say, above 10%. The parasitemia get cleared very quickly. That takes 3 days or 4 days. But then after the first week, you see a second drop in hemoglobin levels, and that can go quite deep before it recovers. So in the second and third week. And it's an hemolytic anemia, so LDH levels, for instance, go up, as you see there in the right-hand graph. A few studies from Western countries. So it happens quite frequent, and especially, as I said before, in high parasitemias. So how can artesunate cause that side effect, whereas the drug itself has this very short half-life, and also the metabolite, dihydroartemisinin, has a plasma half-life of only 1 hour. So after 6 hours, all the drug is gone. How is that possible? Well, the mechanism is that the way the parasite is cleared from the circulation after artesunate treatment is through a mechanism called pitting. And that has to do with the mechanism of action. So when you treat parasites with artemisinins, the parasite becomes very dense. As you see here, you can observe that in patients like microscopically, but also in the Petri dish. So you see these very dense bodies being formed, which is very different after treatment, is after quinine, where you see this vacuolated parasite appearing. And these dense crenated parasites, they are taken out by the spleen through a pitting mechanism. And you see that there in that EM picture, where the parasite is taken out, but the erythrocyte reseals and recirculates. You can still recognize that erythrocyte, but because it still carries Plasmodium falciparum antigens on its red cell membrane. And the one we use for identification is the RISA antigen, and you see that on the right-hand side in that IFA picture. So those red cells still circulate, but they are not normal red cells and have a much shorter half-life. So the lifespan of a normal erythrocyte around 120 days. We observed in these pitted red cells a lifetime of around 8 days. And it's quite specific for the artemisinin. We don't see that with quinine, as you see in that graph. So we did a study in DRC, in the Democratic Republic of Congo, in hyperparasitemic children, comparing artesunate with quinine. We could not study severe malaria because that would be unethical to randomize. And we could indeed see this high pitting rate after artesunate treatment, which was related with some hemolysis, but we did not see this effect what you observe in the non-immune travelers. So a bit deeper dip in hemoglobin, but that was quickly compensated by an early reticulocyte crisis compensating for that. So luckily in these high transmission settings where there is preimmunity and more active spleen, we don't see this happening so often. Still, also there, when you have a child with very high parasitemia, you have to order them back for follow-up after 1 to 2 weeks to see if they have not developed new severe anemia that needs to be transfused. This one I will skip, but this illustrates that in the non-immune travelers, you see this pitted red cell peak a little bit later because probably because the spleen is a bit less active. Okay, this was my last slide. So in conclusion, the artemisinin-based combination therapies, we very much rely on that because they are the first-line antimalarial drugs in all the malaria endemic countries. By the way, that you can also use them for the treatment of Vivax malaria, except artesunate sulfadoxine pyrimethamine. SP is not a good drug for Vivax malaria. So some countries do that, uniform treatment for falciparum and Vivax malaria, except Vivax you need radical treatment with an 8-aminoquinoline or primaquine. Artesunate is by far the best drug to treat severe malaria, but we have this very worrying artemisinin resistance now has emerged first in the Greater Mekong subregion and spread there, and now has independently also emerged in Rwanda and in Uganda, maybe also in Ethiopia, Sudan. So we have to follow that very closely, whether that is not getting a bigger problem. Alternative for the ACTs, the new compounds take another 5 years, so we have to do it with the drugs we have now. So for the endemic countries, we think that these triple artemisinin combination therapies are the way forward, at least for the coming 5 years. Thank you very much. That was the presentation, and open for all questions that you have.
Arjen, first of all, I want to thank you. I don't know if I'm getting feedback here, but I hope you can hear me. That was remarkable. A lot of times during a lecture, you have an aha moment. I had many aha moments during this. It's just a fantastic lecture. I don't know I speak for everyone. It's amazing. I have a number of questions myself, but I want to open it up to the group, and I want to talk to you a little bit. I didn't realize you were an intensivist, so I'm going to talk to you a little bit about managing severe malaria in a non-endemic region. Okay, but before I do that, I have a question from Joanna Daly. And how close are the next generation artemisinins going to be available? Can you comment on that?
The next generation artemisinins. So there will not be as such a next generation artemisinins. We have the synthetic endoperoxides. So arterolane is the only one that is currently being marketed, produced in India, combined with piperacin. So they are available. There was another one in development, OZ439 or artefenomel, for years and years, and it looked very promising in the beginning. Just last year, the development has been stopped for several reasons. So I don't see the development of new artemisinin-like compounds coming up anytime soon. The other compounds that I mentioned, the spiroindolones and the imidazoloperazines, I think that will be the first new generation antimalarials that will come to market in 4 or 5 years.
Okay, thanks. Another question is, what is your opinion? I'm getting a lot of feedback to prolong ACT treatment duration from 3 days to 5 days in non-endemic countries to have less relapse. That was one of the questions.
Okay, first of all, the term relapse applies to Vivax malaria, where you have, the liver hypnozoites, Vivax parasites can relapse. First relapse, it can happen after a month, but it can also happen after 3 months or even 9 months. You don't prevent that with your normal asexual stage antimalarials. So for that, you have to give an 8-aminoquinoline, so a 14-day course of primaquine or a 7-day higher dose of primaquine. Tafenoquine is a new drug that might be useful there. For falciparum malaria, a 3-day therapy is sufficient, and you will see 95% efficacy with the 3-day treatment, and that's the recommended duration. Once artemisinin resistance and partner drug resistance becomes a problem, then that could be an option to prolong to 5-6 days, but that has not been trialed in clinical trials.
Hold on, I'm unmute. Let me unmute. There's a number of questions. So do you think that quinine can be an alternative for severe malaria in the absence of artesunate or in the case of artemisinin derivatives? I don't know what that last part means, but do you think that quinine can be an alternative for severe malaria if you don't have artesunate?
Yes, if there's no artesunate available. The second choice, by the way, is then artemether intramuscular. But if that is also not available, quinine, which was used for severe malaria for 100 years until 2010, is still a reasonable alternative. For the treatment of severe malaria, it's important then to give a loading dose of quinine, because it has a longer half-life and you need to load it up.
Right, thank you. So from Ed Ryan to everyone, do the Kelch mutations affect the ability of artemisinins to oxidate proteins, or do they oxidate normally, but the affected proteins don't get, if I can say this word, ubiquitinated and digested? Hopefully I said that right.
Oh,
Thanks,
yeah,
Ed, for giving me that word.
That is a very technical question. Indeed, there's one study that showed that this ubiquitination, I also always struggle with that word, process, which is the mechanism how damaged proteins are removed from the parasite, is disturbed in Kelch mutant parasite. But there are also quite a few other mechanisms that have been described. I personally like this upregulated oxidative response of the parasite that can be shown in the transcriptome. There are a few other mechanisms being described. It's probably not the activation of the artemisinin as such that's being disturbed.
Great. I'm just going to go up. Oh, I can't go up. So I'll go, Lucille, I'll get to you in a second. So from Michael Libman, I have heard anecdotally and not well documented. Sorry, he moved up because people are actually putting stuff in here. So let me just do this. I've heard anecdotally and not well documented cases of apparent resistance of PO Valley to artesunate. Has this been properly documented?
Yeah, I just got that same question a few days ago from a colleague from Israel. Not that I know, not that I know. No. By the way, the case that I got presented, it could well be, why not, that there is artemisinin resistance appearing in PO Valley. It's a bit unlikely because the drug pressure on that parasite is probably a bit less. But in the described cases, you should have drug levels, because another very common cause of recrudescent infection is inadequate drug levels. For instance, artemethyl lumefantrine. Lumefantrine is notoriously poorly absorbed if it's not given with fat.
Okay, so let me see. Can artesunate be used in cases of parasitemia less than 10% with no clinical signs of severe malaria, but risk for progression to severe form in patients from non-endemic areas? So I guess I'm not sure exactly. You can tackle that.
Yeah, first of all, severe malaria is independent of the peripheral blood parasitemia. So you can have a patient who's severely ill, in coma or organ failure, high plasma lactate, with a parasitemia only of 1–2%. By the way, often then these are late stage parasite, and that has to do with the periodicity of the parasitemia. So it really are the clinical signs of severe malaria that count. If a patient does not have severity signs is not very hyperparasitemia, there is no reason to give parenteral artesunate. You can just very safely treat with an oral artemisinin combination therapy.
I'm going to ask my own question, and then I'm going to get to yours, Lucille. So when I started treating severe malaria in a non-endemic region 30 years ago, I'm giving my age away, I was always taught to bring someone up in terms of fluid management. So that's what the question is going to be: fluid management in severe malaria in ICUs. So I was taught, and this is what I tell people, and then I read something recently that this might not be so true. So I was always taught the person is fluid, depleted, bring them up to euvolemia, but then don't overhydrate them, because that person then may be more likely to get non-cardiogenic pulmonary edema from, leaking. So what are your thoughts about fluid management? Because we get a lot of severe malaria here in New York, and I'm always anxious about fluid management. Can you comment on fluid management?
Yeah, this is a very important question, in fact, and we have done some research on it, and there are some other important big studies on that. So in African children with severe malaria, a big study shows that fluid bolus therapy is associated with a 50% increase in mortality. And there's usually not a good reason to give a fluid bolus, because the patient usually is not hypotensive. Only around 10%, max 15% of your patients will be hypotensive, which is, as such, is remarkable, because you have a big pro-inflammatory response. We think that's because, by the way, the nitric oxide is sequestered by the free heme that is produced during the malaria infection. So there's not a reason to give fluid bolus therapy for hypotension. If there is hypotension, you really should think of a concomitant bacterial sepsis. So also treat for sepsis, and then you have to give fluid bolus therapy, vasopressors if needed. Otherwise, fluids will, you give it to improve the microcirculation, but because of this specific pathophysiology of severe malaria, where the whole microcirculation is blocked by these parasitized erythrocytes, we have shown in our studies that fluids do not lower your lactates and do not improve your microcirculation. It does give, as you rightly mentioned, a much higher chance to develop non-cardiogenic pulmonary edema. So the recommendation is to just give 2 to 3 mils per kilogram per hour fluids, and only give a fluid bolus when you need it because of the treatment of shock, not because of the dehydration of your patient. There are a few liters behind, but you can take your time to replenish that. And you can kill your patient if you give too much fluids.
Great, okay. I think that's such an important point, and a lot of people don't know about. Okay, so from Lucille Blumberg, ARTs, mostly AL, are very widely used in Africa. Is there anything we should be doing to reduce chances of resistance developing, for example, introducing different combos now, different treatments in different cases? Any thoughts on that?
Yeah, thanks for that question, Lucille, who I know well. Yeah, very important question. So artemether-lumefantrine is very widely used. It's the prime ACT in Africa. There are some reports now of higher failure of artemether-lumefantrine from Angola and Burkina Faso. We really want to protect lumefantrine. There are several strategies. So you can use multiple first-line treatments where, for instance, the private sector and the public sector deploy different ACTs, so with different partner drugs. So that you hope that the parasites, the next generation will see a different ACT, so you have less drug pressure and less development of resistance. Another approach that we are currently testing, and we think is a good approach, is these triple ACTs, where you combine your artemisinin with 2 partner drugs that mutually protect each other. We think that can importantly delay, especially this artemether-lumefantrine plus amodiaquine, the emergence of lumefantrine resistance. It becomes, in addition, by the way, very important to protect lumefantrine, because the new drug, which is this ganaplacide lumefantrine, is also combined with lumefantrine. So we really have to protect our lumefantrine. So I hope that answers the question, Lucille.
Lucille, if you have anything else, I'm monitoring the chat. I wanted, Anne McCarthy is asking, can you comment on the use of Tylenol and renal protection in severe malaria? And maybe you can talk a little bit about renal, and we just had a patient go into renal failure here with severe malaria. I have found that, over time they actually improve if they actually survive the malaria. So maybe you can talk a little bit about the kidney, malaria, and Tylenol.
Yes, we've done studies ourselves on that, so that's a nice question. More in general, acute kidney injury in severe malaria is quite common in adults, a bit less so in children, but probably under-recognized in children. The pathophysiology is an acute tubular necrosis. Not all become oliguric, can be non-oliguric. And as you say, if you give renal replacement therapy, it will restore after around 10 days. Paracetamol is very interesting. So paracetamol, besides all the other effects, has a reducing capacity. It reduces ferril iron, iron 4+, back to ferric iron, iron 3+ and 2+, iron 3+, I must say. And iron 4+ is produced during a severe malaria infection because of all this hemolysis of the infected erythrocytes during silent rupture, but also other erythrocytes. there's a lot of free hemoglobin floating around, which is very oxidative for the kidney, as we know from massive hemolysis in general. You can ameliorate or prevent this kidney damage by giving paracetamol. And we have shown this in a small randomized trial in adult patients in Bangladesh. And we are just starting a much bigger trial in African children to test this same mechanism. But there is a very nice pathophysiological mechanism that we described. We shown in a small study that it works. But to be honest, we need confirmation in a bigger study. But, you know, why not give 3 grams of paracetamol to your patient that comes in with severe malaria?
Okay, thanks. That's interesting. So Dan Bork is asking, given some data, though limited, there's some suggestion there may be an increased failure rate with AL in non-immune travelers. He has a travel clinic in Boston, and that there is limited data of increased AL failure in individuals with weight greater than 65 kilograms. Should we consider an alternative of ACT like Malarone in non-immune travelers with weight greater than 65 kilograms?
Yes, I think that is not a problem of resistance, but that is a problem of underdosing in patients over 55 kilogram. Yeah, I would just give a bit more of AL, or it's really underdosed in more heavy patients. Malarone is an alternative, but Malarone is a weak antimalarial, so you will see very slow clearance of the parasitemia there.
Okay, I have, I don't think anyone else has any. Wait a second, let me just check because I have some more. So I just wanted to ask you 2 follow-ups. When you have somebody with severe malaria, like we have recently, and they have 25% parasitemia, and we gave them artesunate, we're getting bloods every week. And then, of course, educating the patients about symptoms of hemolysis. And we'll see them every week for 4 weeks out. Does that sound appropriate to you?
Yeah, that sounds appropriate. Yeah. I was thinking you were going to ask about exchange transfusion.
Oh, I wasn't. We don't do it,
okay.
but I don't know about other people. So, but why don't you comment on it for others? Yeah.
Yeah, because that's in some centers that is quite common practice. But with artesunate, it's so rapidly killing the parasites that even with very high parasitemia, there's not a real indication for exchange transfusion anymore. There are no randomized trials, but from the retrospective studies, there's one bigger one, did not show additional benefit from exchange transfusion with artesunate use. Yeah.
So I'm just looking to see. So I'm going to throw something out totally different because I don't see something. You may not be able to comment, but there's such a difference in Africa with the eye findings reported out of Malawi versus the eye findings and also MRIs found in adults in Asia. You know, it just seems very different. What is your thought about the pathophys with that? Do you have any thoughts on that? You know?
Yes, I have. I think also in African children, the primary the primary event is sequestration in microcirculation. So the retina findings in Malawian children is very much the same as the adult patients that we studied in Southeast Asia. Regarding cerebral edema, that is indeed more common in African children later on in the course, which is different. It doesn't change the treatment because the trials that have been done with mannitol do not see an improvement in mortality using mannitol. But that is indeed a difference compared to what we observe in Asian adults.
Thank you. I'm just looking to see if there's anything else coming through. It looks like I have asked all the questions, and Lucille made a comment at the beginning, and she said this was a masterful presentation. She said it much better than me. It was really fantastic. You can't see, you'll see later on, everybody complimenting this presentation. Arjen, this was an absolute pleasure. I am honored. I speak for New York and everyone on the phone. We're all honored to have you. And thanks for actually giving so much back to the malaria literature. It's incredible how much you and your group have elucidated on this topic. It's pretty awesome. So thank you on that note also.
Thank you very much. It was my pleasure.
Great. And hopefully we'll be in touch soon. Thank you. Great.
Have a good
Bye-bye.
day. Bye-bye. Bye.